So, welcome everybody today to our INNEG webinar. Today we're talking about scarring and disfigurement, and we have Professor Stephen Jeffery, a consultant burns and plastic surgeon, joining us today. Before we begin, as you may well know, INNEG, we run this series of webinars every month, and we are looking at adding value to our solicitor clients across both personal injury, clinical negligence, and beyond. One of the fantastic tools which we've launched on our new website is a tool which allows you to search for expert witnesses and to see the number of expert witnesses we hold in any specific discipline. You can also go in, and besides for seeing the number, you can also see the number of sub-specialist areas that we have within our expert directory, allowing you much better insight to decide whether to reach out to us when you have an appropriate case before you've actually sent that email. Anyway, enough about us. To introduce Professor Jeffery, I'm delighted to welcome him. He's one of the UK's experienced consultant plastic surgeon, and he's a highly recommended, respected medico-legal expert. He has over 25 years of expert witness experience and specializes in burns, traumatic wounds, scarring, and reconstructive outcomes. He's a consultant plastic surgeon at University Hospital Birmingham and a professor at Birmingham City University, and has published over 90 papers. Many of you may also recognize him from the BBC series Surgeons at the Edge of Life. To let you know, Professor Jeffery will now be taking over. There is a Q&A session afterwards, and at the above, please pop in any questions that you might have, and we will try and get to as many of them as we can. And the slides will be provided in an email following this event. So without further ado, Professor Jeffery, thank you very much for joining us today, and over to you.
Thank you very much. Thanks for the opportunity to talk on scarring to this large group of people. And yeah, I think you've read all that already. It's basically I did a full career in the army. I did 35 years in the regular army as a plastic surgeon when I was at Birmingham, and now I run amongst other things, I'm the Chief Medical Officer for the Pioneer Wound Healing and Lymphedema Centres, which is the UK's biggest private wound care and scar care company, and we sell our services to the NHS and also to self-pay private patients. So what we're going to talk to do today, these are some of the things that we're going to talk about. And first of all, to understand what a plastic surgeon is, because not everyone fully understands it, because there's a lot of conflicting terms: cosmetic surgery, plastic surgeon, cosmetic surgeon, and it's not a protected term, so anyone can actually claim anything about themselves. Some causation terms that cause a little bit of confusion, and then in terms of what you should expect from your report, well, your surgeon should be taking a history from the patient first of all, and giving them the symptoms that the client is complaining of, and then on examination, what your report, how the scar should be getting described. Then talk a little bit about confusion between what is a scar and when it's a scar and when it's a blemish, and then go through some of the scar treatment options. Talk a little bit about burns, because there are a few little peculiarities about burns that are different, and then we'll talk a little bit about non-accidental injury cases. So in terms of what is a plastic surgeon? How do you how can you claim to be a plastic surgeon? How can you know that the guy doing your report actually is a plastic surgeon? So the thing to do is to find out their GMC number, and then go into the GMC. If you just type in GMC into your website, you'll quickly come up with this sort of find a doctor, look up a doctor on their register, and then type that GMC number into the search our registers, which is what I did. For this one, I just put mine in, just as an example of what you should be looking at, what you should get. And then, so this is what it comes up for me. So the first thing to say is I'm registered with a license to practice. Now, you might be surprised that not all your people that write the reports for you will be licensed to practice, because often this kind of thing will be done as a kind of almost, I don't know, hobby is too strong a word, but it's something done by retired people. So they say, oh, I'm not seeing patients anymore. I don't need a license to practice because I'm not actually practicing medicine, am I? I'm just doing these medical reports. But if in that medical report you're going to put about recommendations for treatment, then the GMC is quite clear that that actually is practicing medicine, and therefore does need a license to practice. There's the barrier. Why they want to do that? Why do you think that people want to get rid of their license to practice? Is, first of all, you've got to pay money to the GMC annually. Secondly, you have to have appraisals annually, and you have to go revalidation every 5 years, and that puts some people off, because some people don't enjoy the whole appraisal revalidation process. So they say, I'll just take myself off the register, but keep doing these reports. And I know that nearly all of these cases, most of them, never ever see the inside of a courtroom. But if they did, and your expert wasn't who he claimed to be, then the barrister's going to have quite an enjoyable time ripping the evidence to shreds. So to avoid that, you want to make sure they've got a license to practice. The second thing to notice is it says the doctor is on the specialist register for, and then my particular case, for plastic surgery. So that means I am actually entitled to be employed as a consultant plastic surgeon. And if you haven't got that, then you are not a consultant plastic surgeon. You might be you might be a trainee, or you might be someone that's fallen off the training ladder for one reason or another. Okay, so next, just some little thoughts about causation. Causation, usually in the kind of cases I get involved, it's usually pretty straightforward. It's fairly obvious, that road traffic accident happened, that they did trip up over that curbstone or whatever. The mechanism of the injury is usually, for civil cases anyway, usually quite clear. Sometimes the word laceration is different from the word cut. So a laceration implies there's been a tearing motion, so that's from lacerated to tear. Whereas a cut is an incision, so it implies that there's a sharp bit of metal or piece of glass or something like that. Now, also the word heal also gets misunderstood. So the definition of to heal is to make sound, and from a wound's point of view, that means to epithelialize. Now, the epithelium is the top layer of the wound, and if you look at a cross section through the wound, you can see that it starts out, there's a hole, there's a gap, and then to the third picture on the right hand side shows that gap has been filled. It is now healed. There's epithelium, but it will still be red. But I get, time after time, I get solicitors trying to tell me that the client, it took 3 months to heal, when quite clearly it didn't. So just because the affected area is still red or still sore, that doesn't mean it hasn't healed in the medical definition of the sense. So then we're going to get onto our scarring, and the scarring comes in lots of different guises, and we're just going to talk about some of the parameters then. So first of all, you're going to speak to the client, and they're going to ask them how that scarring is affecting their life, and these are some of the things that you should really be seeing in your report. So, for example, the first one, scarring is a source of embarrassment. There are not many clients where this will not be relevant. Even if I had a scar, I think I would find it embarrassing as well for people to see it. So that phrase should always pretty much be in every report if this scarring is a source of embarrassment. And secondly, the second statement there, the scarring is a permanent reminder of the injury. That is nearly always going to be true. People, they wake up and when they see that scar, even if very, very fleetingly or subconsciously, that is going to be a reminder of the time that the injury happened, and of course all the pain and all the other psychological consequences associated with that. So those first two lines should appear somewhere in just about every report that you should be getting from a plastic surgeon. And then the other things are dependent on the location. So, for example, if it's on the face or the hand, a lot of people who will be working with face-to-face roles will find it embarrassing because they think that people looking at the scarring when they should be talking to them, and also because people wrongly or rightly assume that if you've got a facial scar, maybe that's caused by a fight, and therefore you're a bit of a dodgy character that gets into fights. So if you're a professional person and you're trying to give across an image of being very professional in your manner, then having a facial scar can detract from that. So you would think that should appear in the report. And the same with hands, because hands they're a social interaction tool. People look at your face and the people look at your hands. And if we shake hands with someone, they're going to notice any scarring on it. If you've got scarring on your wrist, some people are embarrassed that this may resemble deliberate self-harm. And again, that there is a stigma associated with that in our society. So this can be a cause of embarrassment to them. If you've got scars on your legs, women particularly, but increasingly men too, are telling me that they think they won't go swimming, they won't wear shorts, they won't wear short skirts, dresses, etc., even in the hottest of weather, because they don't want people to see and notice and comment upon and judge them because they've got scars on their legs. Some people have color changes rather than any scarring as such, particularly if you've had a burn. The burn might heal completely without a fade, a trace, but you might, when they get in the shower, for example, that area might become red. So ask them about that. Also ask them about itch, because that can be quite annoying, particularly for burns again. If there has been any kind of wound, you might have reduced sensation in the skin distally, which means the further south than the scar itself, and that's because whatever caused the damage to the skin might also have damaged one of the sensory nerves. So always ask about that, because some people find that annoying. So these are the kind of things that you should be getting in that the history section of the medical report. And everyone does their medical reports slightly different, but usually there's a bit about how it affects the patient's life. And then secondly, it comes on to the examination. And once you start going through this, you'll perhaps realize why plastic surgeons don't usually like doing remote consultations. And I know during COVID we had to do them remotely. There was no option, but you're not going to get some of these descriptors in if you haven't actually put your hand upon the scar. So obviously there's the length of the scar, and there can be a width of the scar that can be measured, although don't expect us to measure it if it's a remote consultation. Whether there's a cross-hatching. The other thing about measuring a scar is if in a prison visit they won't let you bring tape measures in. So I rather sneakily on my laptop here I have a tape measure sellotaped to my laptop at the bottom just below the screen, so that I can go and measure the the scar with my fingers, and then I can say it's so many centimeters by so many centimeters. The joys of doing prison visits. Anyway, so the next bit about whether it's raised or flat or indented. Now that is hard to get from a photograph. Sometimes it's clearly obvious from a photograph whether it's raised or indented or not, but usually, because our photographs are 2D, that something is best experienced face to face. Whether it's soft or firm, definitely you need to put your hand upon that, your fingers on that scar, and feel it whether it's soft or firm. Like that, that is the point where you would discover whether it's tender or non-tender. Because if it's non-tender, they will not complain, but if it's tender, they will. That is also the point where you discover where, by moving the scar skin over the underlying tissue, whether it is tethered to the underlying tissue or not. And this is something that doesn't perhaps come out well in a photograph, and would be best if we could, if sent in a video. So occasionally, as well as sending photographs with my reports, sometimes it's appropriate to send a video, because there are some bits of tethering that only really show up on movement and don't show up in that static 2D photograph. There could be an associated divot. That's particularly where the scar is over an area of fat, and the trauma that caused the scar also hit the fat, and the fat has got a poor blood supply and will often die as a result of fat necrosis, and you might get a divot under the scar. I was going to show you an example of pin cushioning in a minute, and then what I like to do, particularly with facial scarring, is describe whether it is visible from a distance of 1, 2, or 3 meters, and that, I think that is just this kind of a crude kind of indication of the severity of this unsightliness of the scar. And then when it comes to describing whether a scar is ugly or unsightly, I normally put that in the opinion section rather than on the examination findings, because what I might call ugly might be every man's got his own sort of views on what is ugly and what is unsightly, etc. And that is my opinion rather than a medical a fact as such. So those are the descriptors that one would expect to be recorded somewhere in the notes. Usually, most of it's in the on the examination findings. So here you can see the top left is an example of pin cushioning, where you can see there's been a almost circular scar, and what happens with the scar is it will contract slightly, so it'll shorten, and in doing so, it brings the tissue that's in the middle, it makes it a little bit plumper, like a pin, like a cushion, and that's more evident, in real life than in a 2D photograph. Then bottom left, what we've got is what's called a dog ear. So you can see that the wound has been sewn up, but they've been left with a little proud bit of excess tissue at one or both ends of the wound, and that can be unsightly. And then on the right hand side, you can see an example of tethering. Here there's a skin graft scar, and it's tethered to the underlying muscles, and that will be, again, as I said earlier, most evident when you move the limb. So consider getting a video of that rather than a normal photograph. Right, so the difference between a scar and a blemish. So the definition of the words of a scar is that it's a permanent mark in the skin. So you can't, if people say, oh yeah, I had a scar for 6 months, but now it's gone, that is nonsensical, because where's the permanence of that? If that is the case, it was a blemish. Now, you can only truly diagnose a scar by feeling it, because then you will palpate the scar tissue, whereas a blemish will be completely flat. You cannot feel it, and will improve with time. Nearly always will improve with time. The blemish can be hypo or hyperpigmentation. So again, if you see, if your surgeon gives you a report that's done remotely, they should say that they can't really distinguish between a scar and a blemish. I mean, there are some photographs where it's barn door obvious that this is raised, like some of the ones I showed you earlier. But when it's less, when it's more subtle than that, then you can't really tell. Therefore, you can't give a full prognosis. We've got a hand up from Alicia. Are we dealing?
We will deal with questions at the end, Professor Jeffery. If
Okay.
anyone wants to just throw a question into the Q&A function, we'll come to them at the end.
Yep, that's great. Okay, so for example, these are the same legs. At one stage, the one on the left is I would say it was hypopigmented, and the one on the right is hyperpigmented. And you often get that in the winter it's paler, and in the summer it's browner. But the good news is it will eventually go completely. How long that takes varies from skin type to skin type, and it takes longer in the darker skinned individuals, I would suggest. But you can see this is the kind of improvement that you get gradually. We don't fully understand the mechanics of this, but gradually the pigment cells repopulate and start producing the melanin that gives you the color. So you no, this is they've said before and after, but that isn't the case in these. These are different parts of the body. But these are just examples of scarring where they're trying to tell the difference between a keloid and a hypertrophic scar. So the definition of a keloid scar is where the scarring starts growing in the tissue that wasn't actually affected initially, whereas a hypertrophic scar is just the normal scar except on steroids, so to speak. Although that's not a very appropriate term, because that's how you treat scarring. But if it's a sort of supercharged scarring is hypertrophic scarring, whereas keloidal scarring, and everyone thinks they've got keloidal scarring, but nearly always it's hypertrophic. Keloidal scarring is actually quite rare, and the scarring actually grows out with the confines of the original scar, and it's actually very difficult to treat. This isn't before or after either. Ignore it. These are different patients. This is an exception to that blemish thing that I said, that blemishes nearly always get better. So this is staining that you get in the skin from iron transfusion, so ferritin transfusion, transferrin, etc. transfusions, which I used to see occasionally for the maternity patients. Obviously, maternity patients often a bit anemic, and the doctors want to top them up a bit, so they can give them supercharge them by giving them some iron in through a vein. But the problem is that if you get an extravasation injury, which is where the iron leaks out from the venflon and doesn't go into the vein in the normal way, but leaks out into the normal tissues, as sometimes does happen if you have any kind of cannula in the skin, then you get this horrible staining, horrible kind of grey staining, which actually without treatment is permanent. But I think I've been seeing it recently, quite a few. I've seen about 12 this year already. People who, believe it or not, are getting iron injected in clinics for sort of health reasons and beauty and kind of aesthetic reasons. They're having all kinds of things, strange things injected, which is great if it goes well. But if it doesn't go well, then you're going to end up with this kind of appearance, which the good news is it is treatable with a laser. So scar treatment options, and what we're going to do. Well, the easiest thing to do with a scar is to do nothing, because scars, we know, most scars do get better with time. And that is truer the older you get. One of the few good things about getting older is that you scar less as you in response to injury. So if you're going to have your surgery, have it when you're older, not when you're a baby. Most people are not happy with doing nothing, though. They want something done. So what options have we got? So if a scar is red or raised or firm or itchy, the first thing to try is scar therapy. And by that we mean the application of massage, silicone, and pressure. Now, the massage, you just have to use any kind of lubricant, any kind of white cream that they've got lying around, and then you rub it into the scar until it blanches. That's how you know that you're going firmly enough, and you have to do it for about 10 minutes or so until and do that twice a day. And so they have to be instructed on that. Then you dry the skin and you put on a silicone patch. We'll talk about silicone. We don't really know how silicone works fully, but it does. If you treat half a scar with silicone and half not with silicone, you'll see a difference. And then likewise with pressure, there are some parts of the body where it's difficult to get pressure on. So for example, the chest, it's hard to get pressure applied, but to the limbs, it's much easier. We're going to talk about a little bit about scar revision. This could usually be done under local anesthetic, but will require, normally I think it's reasonable to say how much time off work that would require. So usually it'd be about 1 day off work. Photodynamic therapy, we'll talk about that. People used to call this laser therapy, but with the LEDs now that are around, the LEDs have become much stronger than they much more powerful than previously, and you can get the same kinds of results now from LEDs, except at a small fraction of the price. Talk about fractionated CO2 and how that works, steroid injections, camouflage makeup, bit about fat transfer. And these are basically most of the options that are available to you. So silicone, first of all, comes in different formats, either comes in a gel or something that you can spray on, or it comes in a firm like gel like this, or it comes in a sheet or a roll. It's not particularly cheap, so patients like to have this prescribed. It's better, they want their solicitor to pay for it, essentially. It does work though. There are lots of different types of silicone, and some people find that they are allergic to some kinds but not the other kinds. So it might be worth them having a little play and trying different ones out before they get one that's suited to them. And these ones that are sort of light brown in color actually are, for most people, for Caucasian people, are actually flesh colored, so they can hide a scar quite nicely. And that's the kind of effect that this is a before and after. They've labeled these right. So you can see the scarring before. Although it's a 2D photo, I think you get the impression that of how raised the scars were before, and then just with the application, those simple scar therapy, it is now flatter, it is softer, and the pigment, and it is paler, and it will be less itchy as well. Likewise here, what you can't get rid of, unfortunately, is those cross hatches. Of course, they have been in because stitches or staple have been in too long. Unfortunately, non-plastic surgeons, they love putting these staples and things in the wounds. So they give you this awful result. And then here we go, before and after. You see the pinkness has gone, the raisedness has gone, and if you feel it, it would be softer. And so, for the example, this might now be amenable to putting on camouflage makeup, which we're going to talk about in a little bit, because the problem with camouflage makeup is it won't work if it's raised, because you'll still get, you'll still see it's raised from certain angles. Steroids. So steroids are the most potent anti-inflammatory agents that we have, and scars are red because they are inflamed, and there's too much inflammation going on there. That's why they're raised and firm. So if you put steroids in, then it's going to really dampen down the inflammation, and your scarring is going to become flatter and softer. There is a risk, however, of hypopigmentation, and that risk, hypopigmentation in a white person, isn't the end of the world, but hypopigmentation in a dark-skinned person is going to be much more obvious. But we do use it for injecting scars, and the it's going to need to be repeated, and often it's done every sort of 6 weeks to 2 months. And you often need a course of treatment. So there's not just one steroid injection. You often need between 6 and 10 injections, and that's difficult to predict. But here, that's a typical result here. See, this person had a hard nodule, was itching, causing them problems, and that's actually been a lucky result of one single injection. So next we can do revisional surgery. So this is where you can excise the old scar, particularly if there was a divot or a step in the scar, or also you can actually change the orientation of the scar. And I think it's reasonable. I never quite get my head around, if I tell what the costs are going to be in the report, I get an addendum request back saying, don't put in the costs. And then if I don't put the costs in, I will get an addendum report request saying, you haven't given us the costs. So you can't please everybody all the time. But they're certainly going to be reasonable to put a cost to that, and the length of time off work, etc. And also what the likely outcomes are going to be, how successful that is likely to be. So for example, this lady didn't like, this is a typical sort of laparotomy scar. She didn't like the cross-hatching or the divot. And we can see I just excised that, and okay, she's got that pinkness will, you go back to square one with the pinkness again, but we know that the pinkness will settle down with time, particularly with a bit of scar therapy, and that will make it less noticeable for her for when she's in a swimsuit, etc. Here we can see someone that's got a quite distinctive, I would say, facial scar. What draws your eye to it? Well, first of all, there are horizontal and vertical lines there, and there aren't normally on the cheek anyway, horizontal lines. You're allowed to have horizontal lines on your forehead like I do, like Gordon Ramsay does, but on your cheek, they're supposed to be oblique. And you can see also there's a little bit of a step deformity there, so the upper bit of the tissue is a bit prouder than the lower part. So what you can do, we have different techniques of reorientating the tissues and putting Z plasties in, etc. But what you can do is excise that old scar and reorient it so that there's more of a zigzag going on. And I think you'll agree that it's less noticeable now, and your eye isn't immediately drawn to it as quickly as it would have been in the first image. And again, that's something that can be done under local anaesthetic as a day case. And depending on his occupation, he might need 1 day off work, or if he works in a really dirty place, maybe 2 weeks off work. So, laser treatment. So there's there's different forms of laser treatment. So you're giving energy to the scar somehow, and hoping that's going to transform. Now, the CO2 laser, what the chromophore is, in other words, what the laser is targeting is water. So it hits the water, and the water boils off, and you get ablation. So that the water literally boils off in front of you. Now, if you just did that with the top layers of skin, you'd end up with a burn. So that might not be as good a result as you would like. So the modern concept is to use this in a fractionated way, so a fractionated CO2. And what that means is there's a special head that goes on the CO2 laser that instead of delivering a whole blast of energy to an area, it just breaks down the laser light into lots and lots and lots of very, very, very fine holes. So each hole might be just microns wide, but can be up to 4 millimeters deep. And by you get the very similar to effect that you do from needling. If anyone remembers the good old days of needling scars, except without all the blood and the mess, and it's a much more precise way of doing it. So what are the advantages of using an ablative laser like this? Well, it makes your scar, if you've got a plaque of scar, it turns it into like a string vest, and it makes it much more pliable and thinner, and it usually makes it a lot softer. So for example, if you've got this is before and after, you see he had the hard, firm scarring that was getting tight every time he tried to move the wrist. Now that has completely settled down. Again, this needs a few sessions. It can be done under local anesthetic with or EMLA local anesthetic cream, but it's likely to need a few sessions. Camouflage makeup. I get asked to do loads of referrals for camouflage makeup from solicitors. If there's a contour defect there, it's not going to be that effective because it will still be raised. The other point to mention is the good thing about camouflage makeup is that it lasts for some time, so it's good for the legs or the trunk, etc., where it would wipe off otherwise. But for the face, most people want to wash their face at night. Even I want to wash my face at night. And ladies, it's usually the ladies who worry about getting camouflage makeup. They go as far as washing their face twice a day. My goodness, shock horror. So having long-lasting camouflage makeup on the face is less appealing. I find that in my experience, men won't wear it. So I get asked to refer all the time, but I know it's very sexist and old-fashioned to say it, but my experience is that if you prescribe it for men, they just don't wear it. It will stay in a cupboard in a drawer at home. So there's when sizing up the costs of camouflage makeup, there's obviously the cost of the initial consultation. The first year's costs are going to include the costs of application, brushes, etc. So its first year's costs are going to be more, and thereafter there'll be the annual costs. And most people would like to have a sort of summer color and a winter color, if you know what I mean. Because most people are more tanned in this country anyway in the summer. Fat transfer, I think you can imagine what that does. What you do is, so this patient here has got a lost fat underneath the scarring, and it's actually the divot that is more noticeable than the scar itself. So what this will entail is taking some fat by doing some liposuction, usually from the tummy, and then injecting it under the scarring. Now, the problem with fat transfer is when you do fat transfer, not all the fat survives the journey. Only about half or 2/3 of it will survive the journey. So it depends on how you're whether you're an optimist or a pessimist. So do you overcompensate and then hopefully some of it's going to die, or do you get it just right and then go back and have a second go. Most people are in the latter category. They'd rather try and get it right rather than overcorrecting it. So that means that there's likely to be a second or even a third go required. And remember that if they've got pain associated with the scarring, the fat transfer is probably not going to make that go away. So burns, now we're going to talk about. So just a few concepts that may not be sort of obvious to everybody. But as a burns and plastic surgeon, I know that if a burn takes less than 2 weeks to heal, they are not going to have a scar. That's pretty much guaranteed. So if I see in the records that it was healed at 5 days, I know before I even examine them that I'm not going to see anything. But they, clients and solicitors don't quite understand, sometimes not all understand this. Whereas if your scar takes more than 3 weeks to heal, you are quite likely to have a scar. And it's that 2 to 3 week window, which is where the burn surgeon really earns their money in trying to decide whether to do surgery or not. If you have scarring from your cup of tea, scald, if you've got milk in it, you're not going to get a scar. Very unusual to have a scar if there's milk in the tea. If it is without milk, it will only leave a scar if it is really, really hot, fresh from the from the kettle or teapot. So I always ask a detailed history about how exactly did they make that cup of tea, because everyone makes their cups of tea differently, if they've what a lot of people, I'm not a tea bag fan, I'm afraid. I'm an old-fashioned tea leaf person, but there are some people who like to use these tea bags, and what they do is they will boil the kettle, they'll put the hot water into the tea bag, and then they'll leave it on the windowsill for 5 or 10 minutes. By then it's cooled down that you're not going to get a scar. Chemical burns. So chemical burns, you're going to get all the sort of usual signs and symptoms of a burn, but what they could be left with, even once the burn is completely healed without anything to see as such, they can end up with a dermatitis there. So they can end up with a kind of eczema kind of appearance, and that's caused probably by some kind of sensitivity, becoming allergic to whatever was in the chemical agent. The picture on the right, that's up on the screen now, is to bring me on to non-accidental injury, because often in the family court cases, the pictures like this, and they're saying, are these cigarette burns? And it's hard to tell if it's a cigarette burn. What really aids you is time. Time will aid you, because, so for example, this isn't quite, the picture's a little bit been cropped off here, but can you see in the upper photograph there's a mark on the child's wrist that has might be a cigarette burn, but if the next picture down is what they look like the week after, then it wasn't a cigarette burn. Because if it was a cigarette burn, then it's going to be deep, and the deep burns leave a scar and take over 3 weeks to heal, as you already found out. Whereas the great mimicker of burn injuries, impetigo. So impetigo is a bacterial infection that is very common in toddlers. It also is common in these in houses where there is a bit of maybe social deprivation, which is the kind of people that get taken to family court, for query non-accidental injury. The reality is, the social workers are more likely to pay more attention to these kind of in the socially deprived families, rather than the sort of the wealthier ones. And so they get this impetigo, and then what the pediatrician. Some of the pediatricians are a bit naughty. They see them once, they say, "Oh, it's a cigarette burn," and they phone up the police and they get the child protection and everything, and the child is taken into care. And it's not until they don't make any follow-up arrangements for the child. And it's not until I get to, it's often about 9 months, 12 months later sometimes when sent the photographs and asked to comment on them, and it's been burned or impetigo. So that is a shame if children are being taken away from their parents. Likewise, if this is the same child, this was the child was taken away because they said it parent must have put caustic burns or something to the face, but that was a week later. So that's what impetigo does. That's not a burn. That cannot be a burn. But yet these things, often it takes a year or 2 years later by the time it gets to court for this to be pointed out. And for these family cases, the best thing is to take lots of photographs and take them serially. And you're the best guy to obviously trying to find out what was the putative cause that caused this kind of thing, and what your expert should be able to do is to line up the holes. So in this case, what caused the accident, and I think it's fairly clear when you see something like that in court that this is what has caused the injury. If it clearly matches up, then there's very little doubt that can cause the injury. And the mother will always say, "Oh yeah, the iron fell," but saying, okay, iron fell, but 7 times the iron fell, really, that's so not. Yeah, there's not many of us who do the non-accidental injury work. It's very poorly paid, but very, I think, sort of spiritually worthwhile. I find it very psychologically rewarding to get to be either helping get these children out of a terrible situation, or reuniting them with their parents. So yeah, I'm going to leave it there. Is that my email address? stephenjeffrey@inneg.co.uk.
We've put one in for you as a holding email, so people don't send you a billion emails over time. But don't worry, your CV will all be provided to the solicitors after the event with the presentations. First of all, thank you very much, Professor Jeffery. That really was quite an interesting and thoughtful insight into obviously scars and burns. If there are any questions, again, just please put them in the Q&A. Before I take any questions and ask for you to answer them, Professor Jeffery, I just want to make all of our viewers aware that in the beginning of January, on the 14th, after the new year, we will be joined by Mr. Glenn Smith, an advanced nurse practitioner, and he has more than 25 years of clinical experience and has been an expert witness for many of those. And he'll be exploring nursing failings in preventable fall-related injuries. So that will be marketed soon, and please join us for that one in the future. So just jumping into a few Q&As if I can. Can I ask, where do you see, Vanessa has asked, where do you see the most common mistakes in medico-legal reports around scarring, particularly in assessing visibility, severity descriptors, or functional impact? Because you must see a lot of reports from the opposing side, whichever side you're representing. Do you see a lot of common mistakes?
Yeah, I mean, I think I've covered some of them already about this difference between a scar and a blemish, and also about when a wound is healed or not. Because it just, when I read that, the burn took 6 months to heal, and there is no scarring, I can tell that the person writing that report is an idiot, or is not, but not an idiot, but is not a plastic surgeon, because they don't know. They're certainly not a plastic surgeon. It just makes you think, my goodness, why is this patient doing this work? So mostly it's about that, about definitions. And I'm sure, solicitors must take my reports and laugh at them about, when I try and if I ever wrote about any legal terms, etc. But there are certain phrases which shouldn't ever come together. Things like, he had a scar for 6 months, but then it went away. That's a nonsense.
Yeah. And any
that's
competent plastic surgeon should know that. So if you're seeing that in your report, then perhaps your instructed expert is not quite as competent as they first seemed.
Well, yeah, look them up.
So James Fennell has asked another question. Is there a time post-injury at which scar revision surgery becomes less effective, or any of the other options you've suggested?
Oh, that's a good question. Yeah. So we talked about the scar therapy, that when the scar's red, once the scar, and we know that scars naturally will fade with time. Once the scar is pale, that means the inflammation has gone. So it is no longer amenable to any of the biomodulation, such as scar therapy, massage, etc., like that. The only thing you can do now is rearrange the tissues or chop out the scar and hopefully start again. And likewise, you shouldn't really probably do any of the revisional surgery until the scar has had a chance to settle down, because nature might settle it down on its own. So I wouldn't rush in to an excise a scar that was still red. I'd wait for it to be pale.
Thank you very much. A couple more so far have come through. Lindsay Evans has asked, what would you suggest is the best treatment for pin cushioning between the eyebrows interestingly, caused by a kick from a horse? I don't know if that can be answered quite as easily, or whether it needs further insight.
Did you see the one where the Zs were introduced? If you do that into the edges of the pin cushioning, it generally will blend it out and feather off because what you're looking really is the contour between a raised area and then a flat area. And by doing that, you can feather it off by using the zigzags approach.
Fantastic, thank you. Sophie Bullimore has asked, dot micropigmentation has been recommended in a case. Is this a common recommendation?
It isn't common, because this is like sort of tattooing essentially. So there are occasions like the vermilion of the lip, etc. Perhaps if you've got a white scar on the pink of the lip, then that might be an indication for it there. Ladies like doing it for their eyebrows. I personally think it looks awful, but I think that's a judgment thing.
Thank you. Carrying on, are you okay to carry on with a couple more?
Yeah, certainly.
Fabulous. So Leanne Day has asked, first of all, thank you. In terms of children, are you able to predict how scarring will look in the future once they are fully grown?
Usually, the scarring will grow commensurately with them, unless it's a skin graft. If it's a skin graft, often the skin graft will get a bit smaller commensurately. It will still grow, but it won't grow at the same rate as the bones grow. But for simple scarring, so like linear scarring, etc., wound incisional healing scarring, that grows with the same rate as the bones. Unless sometimes if it crosses a joint, sometimes it can cause a bit of tightness because it restricts the full extension of that joint. But usually it grows commensurately. Most scars won't cause any problems.
Wonderful, thank you. Andrew Tyndall has asked, are you able to give examples of preventative measures to reduce the risk of skin breakdown as a result of impaired skin integrity caused by scarring?
So if it keeps breaking down, that means that the skin is too thin. So the best thing to do is to excise the whole area and start again.
Thank you. I'm going to quickly go through. We've actually got a tremendous amount of questions, which just goes to show about how interesting everyone has found this webinar. So thank you again. Jamie Swain has asked, could scarring on the stomach cause issues in future pregnancy?
It would have to be pretty extensive. If it's a skin graft, yes, it might cause tethering, but most scarring will stretch. The tummy will only grow at a certain rate per day, and most scarring will be able to stretch accordingly, but with the exception of skin grafting.
Thank you. And Jane Penman has asked, do you also report on cosmetic treatments such as fillers, where there is alleged negligence?
Yes.
Well, that's an easy one then, Jane. Yes, you do. Joanna Kane, apologies. Are there any alternatives to camouflage makeup that might work in the same way that are water resistant, so are more appealing to men? I think you already answered this, that any makeup would work, assuming it fits the person.
Go to a good counter at your local department store.
Fabulous. June Makings, recently a defendant beautician recommended a client exfoliate hyperpigmentation marks and then use a sunbed to blend the skin colors. Is this safe?
It's mumbo jumbo.
Mumbo jumbo. It definitely sounded like it. Thank you. Kuram Hussein, a GP may give an opinion on scarring, but does not consider the future outcome of that scar. When might a scar actually require plastic surgery input? I would perhaps venture to answer this for you if I can, Professor Jeffery. Obviously, if it's relating to a scar, a plastic surgeon should be the one commenting on it. That falls within their clinical area. I don't know if, Professor Jeffery, you think a GP should ever be giving opinions on scarring.
Yeah, no, I agree with you. And normally they do that. They defer to a plastic surgeon.
Yep.
So that's what we're here for.
Absolutely. And just lastly, Arena Finnegan has asked, can a keloid form despite proper wound management can a keloid, if I've pronounced that correctly, can it form despite proper wound management and no negligence? And does an appearance of a keloid indicate anything about the quality of care provided, or is it a recognized risk?
Yeah, no, it's a recognized risk. If you're the kind of person that creates keloids, and they say sort of very, very dark-skinned people, or also conversely sort of very redhead people. If you're going to get a keloid, they're going to get keloid. They can have the best of care in the world, and they'd still get the keloid.
Thank you very much. And that brings an end to the very many questions we had. I think on behalf of everyone, want to thank you for your time, Professor Jeffery. Really appreciate it. That was very, very insightful. And to everyone, wishing you a lovely rest of day.